Apologies for the slight delay, everyone. Thank you and welcome back to the ACIP meeting. We are going to now reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers, we have a very limited public comment period today, and in order to make it through all the listed speakers, we ask that each speaker limits his, her, or their remarks to 3 minutes. There will be a timer on the screen so you know how much time you have left. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker is Mr. Edward Nierenberg.
Sorry about that. I just wanted to say good afternoon first and thank the ACIP, CDC, and the FDA for their continued tireless efforts in keeping the American public safe through their guidance and the transparency with which they've conducted themselves. And I find that to be truly commendable. I do want to highlight several concerns. The first of these, I think, is the urgent need for a vaccines for adults program. Vaccines for children is a critical tool in our arsenal for protecting kids. And I would second calls for simplification of the vaccine schedule and echo concerns on voting on the meningococcal vaccination to date before those recommendations have been revised. And I think that we may be putting the cart before the horse there. I would also like to ask that in the future, there be closer communication with manufacturers regarding what is feasible for implementation to allow for better scale up as new products are rolled out. I'm really thrilled that nirsevimab exists. It's a tremendous triumph of our science and medicine to have this passive immunization as an option. But right now, demand far outpaces supply, and in large part because the breadth of the recommendation by CDC covered far more individuals than the manufacturer was prepared for. And I don't think that the recommendation was a mistake. I wish to be clear about that. But in creating such a large demand for the monoclonal antibody, many parents are now finding it impossible to obtain, and consequently children are forced to rely solely on maternal antibodies for protection. I would also like to finally underscore the devastating effects that mis and disinformation continue to have on public health. And I implore that regulators and CDC respond to it actively. Recently, the Surgeon General of Florida, who in the past has tampered with investigations of vaccine safety to fabricate findings of mortality signal that is not present, released a provider alert enumerating numerous canards about the safety of vaccines regarding mRNA vaccines and urged that they not be given to those under 65. There might be room to debate the value and necessity of a COVID-19 booster in those who are at apparently low risk, although I would note that this group does not begin and end with people who are under 65. That debate fundamentally needs to be based on accurate premises, and in poisoning the well with lies, the Surgeon General is obstructing the provision of informed consent. It is furthermore deeply disappointing to see that at this very moment an extremely poorly done preprint alleging DNA content in the mRNA vaccines beyond regulatory limits is gaining substantial traction on social media, going as far as claiming that the existence of an SV40 promoter sequence in the plasmid that is used to help select for bacteria bearing the plasmid during the production represents a hazard to vaccinees. I think it would be helpful if materials were available enumerating the manufacturing process in greater detail from sources like the CDC to help provide perspective on the matter. Thank you so much.
Thank you, Mr. Nierenberg, and thank you for keeping your comments to 3 minutes. I'm going to ask the team to reset the clock, and we will move on to Ms. Elizabeth Dietz.
Good morning, or well, it's still morning here in California. I'm Liz Dietz from Vaccinate California. Thank you, committee members, again for your dedication to public health, not just today and tomorrow, but all the work that leads up to these meetings. I'm over 65 and I have 10 grandchildren under the age of 15. I look at vaccine policy through those two lenses, vaccines for seniors and pediatric vaccines. A committee member whose name I did not catch said earlier this morning during the Mpox vaccine discussion, we really need a vaccines for adults program. Yes, we do. The cost of vaccines is prohibitive for many. I know this committee rightly has a well-defined role. It only recommends vaccines and schedules, but I want to take a minute to tell you what I'm seeing as a person for advocates for vaccines, both in person in my community and on social media. As Peter Hotez has been saying for years now, the rise of anti-science is deadly. We need a vaccine advocacy program as well-funded and well-connected as the forces that spread fear and distrust of vaccines. This can't be a government program. It must fall to non-government advocacy organizations. organizations such as Vaccinate Your Family and grassroots organizations such as Voices for Vaccines and single disease organizations such as Family Fighting Flus and the many state level immunization coalitions such as the California Immunization Coalition. Rolling Stone recently published an article detailing the amount of funds flowing to the forces, the organizations that are engaged in grassroots marketing of fear, uncertainty, and doubt about vaccines. There's no such flow of funds, none really, to non-governmental vaccine advocacy organizations. And as the recent rollout of vaccines for seniors, the Beyfortus vaccines, as my friend and colleague Edward Nirenberg mentioned, has been disastrous. Anything that increases the difficulty of getting a vaccine a person wants reduces the trust in vaccines. And I urge the committee to consider those factors going forward as they recommend future vaccines. Thank you, committee. I really appreciate your work. That's the end of my comments.
Thank you very much for your comment. Next, we have Joanna Colburn.
Good afternoon. Thank you for the opportunity to comment on behalf of the National Foundation for Infectious Diseases, or NFID. For 50 years, NFID has been educating and engaging the public, communities, and healthcare professionals about infectious diseases across the lifespan. We thank ACIP for its important work in guiding U.S. immunization policy and protecting public health. Although the work of NFID covers all infectious diseases, my comments today will address 5 vaccine-preventable diseases in particular: meningococcal disease, Mpox, flu, RSV, and COVID-19. Meningococcal disease is a serious illness. Even with treatment, approximately 1 out of every 10 people who get meningococcal disease will die. Of those who survive, up to 20% suffer serious and permanent complications. Despite the availability of safe and effective vaccines, many U.S. adolescents are not fully vaccinated. By making clear and easy to understand recommendations, ACIP can help raise awareness about the importance of vaccination to help protect young people from multiple strains of meningococcal disease. Mpox is a rare but potentially serious disease. Thousands of cases have been reported in the U.S., including more than 50 deaths during the 2022 to 23 outbreak. Vaccination of those at high risk is crucial to prevent further cases, yet vaccination rates remain low, especially among Black and Hispanic populations who are disproportionately affected. Strategies are necessary to help increase Mpox vaccination rates among vulnerable populations. Flu, COVID-19, and RSV can each be serious, causing mild to severe symptoms and potentially life-threatening complications. For the first time this season, there are vaccines available to help protect against all 3 diseases, but a recent NFID survey of U.S. adults found that many underestimate the severity of these diseases and do not plan to get vaccinated during the 2023 to 24 season. Fewer than 1 in 4 U.S. adults are concerned about themselves or someone in their family getting infected with flu, COVID-19, RSV, or pneumonia. 43% of U.S. adults do not plan to or are unsure if they will get vaccinated against flu this season. And about 1 in 4 U.S. adults who are at higher risk for flu-related complications said that they were not planning to get vaccinated. Only 40% of U.S. adults plan to get an updated COVID-19 vaccine, and among adults aged 60 years and older, only 40% plan to get an RSV vaccine. For each of these diseases, among those who do not plan to get vaccinated, the top reasons cited included concerns about potential side effects or general distrust of vaccines. These findings underscore the urgent need for greater education and awareness. Additional information about the NFID survey and other resources are available at www.nfid.org. NFID stands ready to work with the CDC and other partners to promote vaccine confidence and ensure that vaccines are used as recommended. Thank you for your time and attention and for your tireless and dedicated service.
Thank you for your comments. Next, we have Mrs. Alicia Stillman.
Hi, thank you very much for giving me the opportunity to speak. And I also want to thank you for everything that you do. My name is Alicia Stillman. I am the director of the Emily Stillman Foundation and also the co-founder of the Meningitis B Action Project. In February of 2013, I lost my 19-year-old daughter, Emily, to meningitis B, just 36 hours after her first symptoms. This summer, my husband and I had the blessing of being able to walk our other two children down the aisle to marriage, and I would have given anything to have Emily there with us. She was funny, witty, and warm, and I know she would have made that day even more special. But I'm not here today to tell you again my sad story. Most of you know it. I'm here as a concerned citizen and a public health advocate committed to making sure that this doesn't happen again to other mothers in other families and to other children. I understand the importance of considering the cost effectiveness of a vaccine when determining how best to recommend it. What I don't understand, though, is why cost effectiveness should be considered more strongly than other factors, primarily the actual feasibility of implementing such a recommendation successfully. I've long looked forward to the day when meningitis vaccination would become simpler. I thought when a pentavalent vaccine would become available, I would be out of a job. There would no longer be need to advocate and educate. But I am afraid that the recommendation you are considering most strongly would further complicate an already complicated issue. PICO 1 would require providers to stock and discuss 3 different types of meningitis vaccines, something you all know they are unlikely to do. The Men-B dose would also remain a shared clinical decision-making recommendation, even though we already know that shared clinical decision-making for the Men-B vaccine has not worked out since it was first implemented. PICO 1 would only worsen the already low vaccination rates for the meningitis B and deepen the equity gap for adolescent vaccination. I urge you to look beyond the cost effectiveness data, consider the real life consequences of your recommendation, and make a routine recommendation for all meningitis vaccine so protection can be within reach for all who need it. If not, we'll continue to see lives lost. It's your duty and your responsibility to mothers and fathers just like me and just like you. Again, thank you for your consideration and for all that you do.
Thank you for your comment. Next, we'll move to Mrs. Patty Wukovitz.
My name is Patty Wukovitz. I want to thank you very much for giving me the opportunity to share my thoughts today. I very much respect the work that you do. I'm a registered nurse. I'm the executive director of the Kimberly Coffee Foundation and co-founder of the Meningitis B Action Project. Meningococcal meningitis vaccination is a topic that's very, very close to my heart. In 2012, I lost my daughter, Kimberly Coffee, to meningitis B at the age of 17, just 3 days before her high school graduation and only a few months before starting college to become a pediatric nurse. Within hours of Kim's first symptoms, her heart and kidneys were failing. Shortly after, she was declared brain dead, and I had to make the unbearable decision to remove my beautiful daughter from life support. Kimberly didn't have the opportunity to be vaccinated against meningitis B. While she had received the MenACWY vaccine, at the time, the Men-B vaccine was not yet available to protect her. It is today, and that's why I'm here. Since Kim died, I've shared her story and educated at hundreds of schools, universities, and medical facilities across the country. I've worked really hard over the last 10 years, but I'm not sure how much of a difference my hard work has made. Why do I say this? Because the current shared clinical decision-making recommendation for the Men-B vaccine simply doesn't work in clinical practice because it's perceived as less important than routine vaccinations. And there's data to back that up. According to a recent study, as many as 49% of pediatricians have not discussed the Men-B vaccine with their adolescent patients, and more than 80% of parents have not heard of the Men-B vaccine. So how can parents act on what they don't know? But today is the day I have been waiting for since I said goodbye to my daughter. Today is a major turning point. We now have a vaccine that can help protect adolescents against all 5 serogroups in one vaccine. The availability of the pentavalent vaccine has the potential to completely change the landscape of meningitis vaccinations, but only if the pentavalent vaccine receives a recommendation that is representative of how vaccines are actually used in clinical practice. Quite simply, shared clinical decision-making recommendations don't work for MenB vaccination. The low uptake rates of the MenB vaccine speak for themselves. Only 3 out of 10 17-year-olds have received 1 dose of the MenB vaccine. As a nurse who administers vaccines, as a public health advocate, and most importantly, as Kimberly's mom, I urge you to consider the public health consequences of how your recommendations are perceived by healthcare providers, by school and college administrators, and by parents and adolescents. I urge you to please issue clear and simple recommendations to end the confusion by giving a routine recommendation for all available meningococcal vaccines. My daughter didn't have the choice to get fully vaccinated, and I owe it to her to make sure that other kids do. Thank you so much.
Thank you for your comment. Next, we move to Dr. Michelle Fiscus.
Thank you for the opportunity to provide remarks on behalf of the Association of Immunization Managers. I'm Dr. Michelle Fiscus, AIM's Chief Medical Officer. AIM is the nonprofit organization that supports the 64 CDC-funded immunization program managers across the 50 states, 8 U.S. territories and affiliated states, and 6 major cities, including Washington, D.C. As a pediatrician and a mom, I would like to thank the 2 mothers who just shared their stories, and I'm very sorry for the loss of your daughters. This has been yet another remarkable year for immunizations. We can protect more children than ever before from serious infection from respiratory syncytial virus. We can also protect pregnant people and older adults from that disease. And now we have the opportunity to bring Mpox and updated meningococcal vaccines into the VFC program. We thank the members of the ACIP for working so diligently to vet the evidence, and we're excited about additions to the VFC program, which ensures vaccines are available to all children, regardless of their family's ability to pay for them. Access to vaccines through the VFC program has been estimated to have saved over 1 million lives, prevented more than 472 million illnesses among children, and has saved over $2.2 trillion in societal costs. This is an extraordinary return on the investment and should rank among the most successful governmental programs in American history. We need to continue to share the success of this program because support for the VFC program is more important now than ever. Immunization program managers continue to be challenged to maintain program operations, enroll new VFC providers such as birthing hospitals, incorporate new products, deal with delays and shortages, chase and mitigate outbreaks of vaccine-preventable diseases, and modify immunization information systems to include functionality that meets the nuanced needs of new products and improved data quality. Yet just last week, the CDC sent a report to Congress documenting that the current funding level of the Section 317 immunization program is nearly $1 billion below the estimated national needs. There are only 64 immunization program managers in the United States and its territories. 2/3 of them are new to their roles since the pandemic and are only just now learning how to manage a program outside of a pandemic emergency response. We all hoped there would be a return to normal operations once COVID-19 vaccines were available, but then it was Mpox, and now it's Nirsevimab and RSV vaccines, and we need to navigate even greater barriers to equitable access that we have faced than ever before. We would like to thank the ACIP, HHS, FDA, and our ever-growing list of partners that work alongside AIM and immunization program managers every day to prevent suffering and death. And we're equally appreciative of the dedicated team at CDC who's worked tirelessly to partner with jurisdictions through these challenging times. Thank you.
Thank you for your comment. Next, we have Ms. Francesca Testa.
Good afternoon, and thank you for the opportunity to speak. My name is Francesca Testa, and I testify before you today as a survivor of meningococcal disease. Children, adolescents, and young adults should not be suffering from or dying from a vaccine-preventable disease when we have vaccines available to protect against it. And I urge you all today to vote to provide the broadest access available to our children for meningococcal disease for men, ACWY, and B. At 17 years old, my life was changed forever when in April of 2006, I came down with what seemed like the flu. And the next morning, within hours, my mother tried to wake me and I was unresponsive, being airlifted to Yale New Haven Hospital, where I slipped into a coma and was put on a respirator to stabilize my breathing. And within hours, I went from being an athletic and energetic teenager to having less than a 20% chance of survival. And over the next week, although my condition stabilized, my recovery was daunting, having to learn to walk again from damage caused by the septic shock and battling severe neurological symptoms. And although I survived, the long-term complications and disabilities will remain with me for the rest of my life. And at 17 years old, it's a very difficult thing to come to terms with. I had not been vaccinated against meningococcal disease. And what concerns me today is that the recommendation being considered most strongly by the ACIP for the pentavalent vaccines will not make the meningitis prevention process more straightforward, but rather further complicate already difficult to navigate clinical guidelines for meningococcal vaccination. And we cannot put a price tag on our children's lives. Shared clinical decision-making does not provide physicians and families with a clear and unambiguous recommendation. Shared decision-making only works if physicians do it, and we know there is great inequity of information across this country because physicians are confused by the recommendation and it is not uniformly adopted. The low uptake rates of the Men-B vaccine speak for themselves when only 3 out of 10 17-year-olds have received even just 1 dose of the Men-B vaccine. Vaccine protection should not be left up to chance. And even though I'm recovered, I will never be the same, and I will battle hearing loss, vision loss, chronic migraines, and long-term cognitive impairments for the rest of my life. In addition to cost effectiveness data, I urge you to consider prioritizing the real life consequences of this disease and the feasibility of implementing your recommendations in a clinical setting to make a routine recommendation for all meningitis vaccines. I would also encourage you to consider that the reason we've seen such low levels of disease is because we have the current recommendations in place. But given the devastating nature of meningococcal disease, we need stronger, more routine recommendations versus complex, weak ones that can only create barriers to uptake. Thank you so much for your time and consideration today.
Thank you for your comment. I want to thank all of our public comment speakers for your willingness to speak with us today. And we want to also thank those who take the time to submit written public comments via the CDC docket as well. We are going to move next to the vote session. Given the complexities of our voting for today, I am going to ask our colleagues from the meningococcal work group to please put up the 2 votes for consideration. I want to just walk through what the proposed vote language is because we have a motion on the table and an amendment to the motion. So Dr. Collins, do you want to speak through the amendment to the motion first, and then we'll go to the main motion so then people are understanding what they're voting for?
Sure thing. So option A is first. Pfizer's MenABCWY vaccine may be used when both MenACWY and Men-B are indicated at the same visit, with a footnote that specifies this includes 1 healthy individuals aged 16 through 23 years, i.e. the routine schedule, when shared clinical decision-making favors administration of Men-B vaccination. And 2, individuals aged 10 years and older at increased risk of meningococcal disease, for example, due to persistent complement deficiencies, complement inhibitor use, or functional or anatomic asplenia, due for both vaccines.
Thank you. And could you please go to the next option? So that was the amendment, which will get voted on first, and then option B if the amendment fails.
So option B is Pfizer's MenABCWY vaccine may be used when both MenACWY and Men-B are indicated at the same visit. This is the same footnote as the previous version. And then if MenABCWY is administered in this way, a second dose of MenABCWY may be administered 6 months later to complete the series.
Thank you. So I just want to make sure our members are clear before we vote that the amendment is option A, which is on the prior slide. If this passes, then the voting is done. If this does not pass, then it goes on to option B, which is the next slide. Thank you. And then we would take a vote on option B. Are there any questions, comments that are, I'm going to limit it to ACIP voting members if there's any clarifications needed or any further discussion needed. Okay. I don't see any hands raised, and I'm realizing I need to ask my colleagues to put their camera on. Thank you, Dr. Paling. So if the members could please put on your cameras for your votes. Thank you. Okay. So we're voting first on option A. I'm going to call on folks in the Zoom screen as I see you. So please, as a reminder, state your name, whether you have any conflicts of interest, and your vote. We will start with Dr. Paling.
Kathy Paling, no conflict, no.
Ms. McNally.
Monica McNally, no conflict, no.
Dr. Long.
Sarah Long, no conflict, yes.
Dr. Bell.
Bell, no conflict, yes.
Ms. Bata.
Bata, no conflict, yes.
Dr. Lair.
Jamie Lair, no conflicts, no.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Talbot.
Kip Talbot, no conflicts, no.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Daly.
Matt Daly, excuse me, no conflicts, yes.
Dr. Sanchez.
No conflict, Sanchez, no conflict, yes.
Dr. Brooks.
Brooks, no conflicts, yes.
And Lee, no conflicts, yes. Dr. Wharton, I'm going to need your help.
Dr. Lee, the amendment passed 10-4.
Thank you. So option A has passed. And actually, Dr. Brooks, could you mute your computer? Thank you. We should proceed to the VFC vote for the meningococcal vaccine. Thank you. So there's a motion on the table, and it was seconded to approve the updated VFC resolution for the meningococcal vaccines. Any questions? Okay, thank you. We're going to start with Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you. Dr. Daly.
And Daly, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Dr. Talbot.
Kip Talbot, no conflicts, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflict, yes.
Thank you. Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you. Ms. Bata.
Lynn Bata, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Thank you. Dr. Paling.
Paling, no conflict, yes.
Thank you. And Lee, no conflicts, yes. So Dr. Wharton, I believe that passes 14 yeses, 0 nos.
That's what I got, Dr. Lee.
Thank you. Before we move on to the second vote, I'm actually going to, well, maybe what I'll do is I'll ask people if you would like to comment on your vote, why you voted yes or no. It would be really helpful, I think, at the end. But let's get through the MPOX vote next, and then I will call on my members if you would like to comment about either of those votes. Thank you.
This is Agam Rao. Should I read the language?
Please do.
Okay, so ACIP recommends vaccination with the 2-dose Jynneos vaccine series for persons aged 18 years and older at risk for MPOX. And the footnotes read that this is an interim recommendation that ACIP will revisit in 2 to 3 years, that dose 2 is administered 28 days after dose 1, and that persons at risk include gay, bisexual, and other men who have sex with men, transgender or non-binary people who in the past 6 months have had one of the following: a new diagnosis of greater than or equal to 1 sexually transmitted disease, more than 1 sex partner, sex at a commercial sex venue, or sex in association with a large public event in a geographic area where MPOX transmission is occurring, or sexual partners of people with any of with the risks described above, or persons who anticipate experiencing any of the above.
Thank you. Any questions or comments?
If you're seeking clarification on the issue that was brought up earlier, Dr. Laura Quilter can provide a little bit more information about the transgender or the reason that transgender or non-binary people are included. Do you want Laura to speak?
Very briefly, will it change the wording of the recommendation?
No, it's actually data driven, and I think Laura can say it in 2 sentences or so. Laura. Laura, unfortunately, we can't hear you. Okay, you know what? I forgot. At any rate, I can say it for her. There was a CDC publication, MMWR, that was published, I believe, earlier this year, that was dedicated specifically to the epidemiology of MPOX in persons who are transgender or non-binary people. And we found that there was, the authors found that population was disproportionately affected by the MPOX outbreak. So we know that women have been very minimally, cisgender women have been very minimally impacted. Transgender or non-binary people, there has been a disproportionate impact of MPOX on those persons. That MMWR is published, like I mentioned, and the exact wording of this was reviewed and I guess endorsed by our health equity experts at CDC, so that it could be as inclusive as possible and ensure that the people who we know are at risk are getting vaccinated.
Thank you. We will move forward with the vote. We'll ask for some of that clarification to hopefully be in the recommendations and the clinical guidance. So the current vote on the table, I'm going to actually call on Dr. Saneas first.
Sybil Saneas, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you, Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you, Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Thank you. Dr. Paling.
Paling, no conflict, yes.
Thank you, Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you, Dr. Talbot.
Kip Talbot, no conflicts, yes.
Thank you, Ms. Bata.
Lynn Bata, no conflict, yes.
Thank you, Dr. Bell.
Bell, no conflicts, yes.
Thank you, Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you, Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you, and Lee, no conflicts, yes. So this vote passes 14 yeses, 0 nos, and we'll move on to the vaccines for children vote for those who are 18 years old. And the VFC vote will align with the vote that was just approved to approve the new VFC resolution for Mpox vaccines. So I'm going to go in reverse on my list here. So we'll start with Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you, Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you, Dr. Bell.
Bell, no conflicts, yes.
Thank you, Ms. Bata.
Lynn Bata, no conflict, yes.
Thank you, Dr. Talbot.
Kip Talbot, no conflicts, yes.
Thank you, Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you, Dr. Paling.
Paling, no conflict, yes.
Thank you, Ms. McNally.
McNally, no conflict, yes.
Thank you, Dr. Long.
Sarah Long, no conflict, yes.
Thank you, Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you, Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you, Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you, Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Thank you. And Lee, no conflicts, yes. So the VFC vote passes 14 yeses, 0 noes. And with that, I would like to open up the floor to ACIP members who wish to make a comment about your vote. It's optional and it's for either vote. Dr. Paling.
Hi, this is Kathy Paling, and so first of all, I want to say thank you to everybody that for a robust discussion about meningococcal vaccines. There is, we know that there's been tremendous benefit from the vaccines that are being administered, and there's a lot more to learn. And my vote no was because I was wanted to vote for a little bit of a broader recommendation. I respect that of my colleagues and believe there are going to be many more conversations to come about meningococcal vaccine. Thank you.
Thank you, Dr. Daly.
Yeah, thanks. I want to address this issue of Men B, and I think what I would say is that so one of the overarching goals of the entire program is to maximize prevention of vaccine-preventable disease, morbidity, and mortality. I mean, that is fundamental in the context of resource constraints and other constraints. So I would expect that the work of the meningococcal work group would include evaluation of a Men B prevention strategy, but I think the problem is that that wasn't the direct question that we were looking at today. So I just want to kind of highlight the distinction there. And in fact, I think conflating those two makes it actually harder to make a decision. So I would say let's focus on the decision at hand, recognizing that there are compelling reasons to reevaluate the strategy that we have right now for Men B, recognizing its rarity, but also its severity. Over.
Thank you. Any other comments? Ms. McNally.
I just want to say that I am in favor of Men-B vaccination. I'm in favor of less injections, and I simply too was hoping for a broader recommendation here. Thank you.
Thank you. Any other comments? Okay. Thank you to my ACIP members. You can turn your cameras off. And without further ado, I am going to ask that we go straight to our next session, which is on adult RSV vaccines. We will take a short break between RSV and influenza vaccine session, but I'm going to ask that we keep moving forward since we're still pretty far behind. Dr. Camille Cotton is the chair of our work group, and I'll ask if she can take us through the introduction and overview of today's adult RSV session.
Thank you, Dr. Lee. Next slide, please. So this past June, the ACIP voted to recommend that adults aged 60 years of age and older may receive a single dose of RSV vaccine using shared clinical decision-making. As you can see on this slide, there are 2 vaccines. Each is a single dose, and both have the prefusion protein. Next slide, please. Issues under discussion since the June meeting include that the work group reviewed CDC safety surveillance plans for RSV vaccination in adults at least 60 years of age. GSK has shared with us results of an immunobridging study showing non-inferior humoral immune responses to RSV vaccination in immunocompetent adults aged 50 to 59, compared with immunocompetent adults 60 years of age and over, in whom efficacy was demonstrated. And so just to be clear, this is just a serology study, not a vaccine efficacy study. The work group discussed the potential role of RSV vaccination in adults younger than age 60 years, including subpopulations that would benefit most from vaccination and equity implications. Next slide, please. The work group reviewed CDC vaccine surveillance safety plans for RSV vaccination in adults over the age of 60 years of age and over, including VSafe, which has launched for older RSV vaccination. And I would encourage everyone listening to this call who interacts with people who are getting the adult RSV vaccine to encourage them to sign up for VSafe so that we can have as much clinical information about this vaccine as possible. Today's session will not include RSV vaccine uptake data or safety surveillance data, as those data are currently premature this early into the vaccination program. And uptake and safety results will be shared at a future ACIP meeting. Next slide, please. So on the agenda today, we will have 3 different speakers. The first will be from GSK, talking about safety and immunogenicity with their vaccine in people aged 50 to 59 years compared with adults 60 years of age and over. The next speaker, Dr. Monica Patton from the CDC, will speak on the epidemiology of RSV hospitalization in adults with a focus on adults in the age group that we are considering now, age 50 to 59. And then Dr. Amadea Britton from the CDC will look at work group considerations regarding RSV vaccination in adults age 50 to 59. Next slide, please. And I would very much like to thank everyone who is contributing to the adult RSV work group, including my fellow ACIP members, many consultants, ex officio members, and liaisons as listed on this slide. And we have had really excellent work groups. We've had many of them, many meetings, and I really appreciate everyone's contributions, which has been just wonderful work. Next slide, please. And I would very much like to thank the CDC contributors who also have done amazing work at this time. I would especially like to call out the co-leads, Dr. Amadea Britton and Dr. Michael Melgar, who I think probably know more about RSV vaccines than anyone else in the country at this time, along with so many people from the CDC who've been incredibly supportive through this entire endeavor. Thank you. Next slide.
Thank you, Dr. Cotton. Next, we will move to Dr. Susan Gerber from GSK to present on the RSV pre-F3 safety and immunogenicity in adults 50 to 59.
Thank you. Good afternoon, and thank you, ACIP members, for the opportunity to discuss our new RSV data in adults 50 to 59 years of age. I am Susan Gerber, RSV Medical Director at GSK, and I'm also joined by colleagues to help address questions at the end of the presentation. Let me start with some brief background on RSV disease in this population. There is substantial RSV burden and unmet medical need in adults 50 to 59 years of age. Rates of RSV-associated hospitalizations and medically attended RSV illnesses are relatively high in this age group, related to the development of immunosenescence and increased incidence of certain comorbidities. Published incidence rates likely substantially underestimate RSV burden due to lack of awareness, standardized testing, and underdetection within surveillance studies. Chronic underlying medical conditions or comorbidities that are associated with severe RSV disease, such as COPD, congestive heart failure, diabetes, asthma, and chronic liver and kidney disease, are prevalent in this age group. Additionally, observed disparities by race and ethnicity are particularly pronounced with respect to hospitalization rates among middle-aged adults 50 to 64 years of age. This slide shows data from CDC surveillance platform RSVNet, and here we see unadjusted RSV-associated hospitalization rates by race and ethnicity for the last 5 seasons. For the 50 to 64 years of age group, there were consistent disparities among Hispanic, American Indian, Alaska Natives, and Black Americans as compared with white non-Hispanic Americans. Along these lines, a recent presentation at ID Week 2023 from Dr. Angela Branch and colleagues showed that young and middle-aged adults with certain underlying comorbid conditions were at high risk for RSV-associated hospitalization, with potentially a disproportionate risk for Black and Hispanic middle-aged adults. Based on this unmet medical need, we conducted a study to evaluate our RSV vaccine in adults 50 to 59 years of age. The primary objective was to determine if the humoral immune response in 50 to 59-year-olds with and without comorbidities that are well established to be associated with severe RSV disease is as robust as that observed in adults 60 years of age and older after vaccine administration. We have previously established high vaccine efficacy in the 60 years of age and older age group. Primary endpoints were to evaluate non-inferiority of RSV-A and RSV-B neutralization titers at 1 month following vaccine administration for the two 50 to 59 years of age groups, with and without comorbidities associated with RSV lower respiratory tract disease or RSV LRTD, as compared to adults 60 years of age and older. Success criteria is defined as the upper limit of the two-sided confidence interval for the geometric mean titer ratio less than or equal to 1.5 and the seroresponse rate difference less than or equal to 10%. Additional immunogenicity endpoints will be examined at 6 and 12 months as the study is continuing. Frequency of CD4 positive T cells were performed in subsets of 50 to 59 year and 60 plus age groups to evaluate the cell-mediated immune response. Safety endpoints were also included, and I'll discuss these in more detail later in the presentation. The study is a randomized placebo-controlled observer-blind multi-country study. On the left are general inclusion criteria. On the right, cohort 1A and 1B were randomized 2-to-1 vaccine to placebo. Cohort 1A are adults 50 to 59 years with comorbidities associated with RSV LRTD, and cohort 1B are adults 50 to 59 years without comorbidities associated with RSV LRTD. Cohort 2 are the 60 years and older adults who were vaccinated. This standard immunobridging non-inferiority approach has been developed to bring vaccines, for example, COVID-19 vaccines, faster to those at high risk for severe disease and has been developed and agreed upon in consultation with FDA. Today, we will be focusing on the preliminary 1-month immunogenicity and 6-month safety results. This study included participants from 8 countries, with approximately 23% from the US. Demographics were well balanced between the vaccine and placebo groups. Clinical characteristics were also well balanced. 37.7% of the 60 years of age and older group had at least one comorbidity associated with RSV LRTD, similar to the proportion within the pivotal efficacy trial. In total, the most common comorbidity was diabetes, and the least common was chronic liver or renal disease. I will now show preliminary immunogenicity results. The first co-primary endpoint was met. The 50 to 59 year age group with and without comorbidities associated with RSV LRTD was non-inferior to those 60 years of age and older for immune responses to both RSV-A and RSV-B. The GMT ratio is expressed by dividing cohort 2 by cohort 1A or 1B, those with and without comorbidities. Non-inferiority was established as the upper limit of the two-sided confidence interval for the GMT ratio being less than or equal to 1.5. Similarly, the other co-primary endpoint was met. Here are the results for the seroresponse rate, or SRR, for RSV-A and B neutralizing antibodies with respect to the same group comparisons as previously shown for the GMT ratios. The seroprotection rate was established by subtracting cohort 1A or 1B from cohort 2. Non-inferiority was established as the upper limit of the two-sided confidence interval for the SRR difference, less than or equal to 10%. Notably, a subset of study participants across these age and risk groups had CD4 positive T cells measured at 1 month after vaccination or placebo. All groups who received the vaccine had an increase in CD4 positive RSV pre-F3 specific T cells observed at 1 month after vaccination. Increases in the 50 to 59-year-old age groups were consistent with those observed in the 60 years of age and older age group. Moving now to the 6-month safety results. Here are the results of the solicited adverse events reported within 4 days of vaccination, a comparison between 50 to 59-year age groups with and without comorbidities associated with RSV-LRTD, with placebo groups, along with comparison to the 60-plus-year-old group. There were low frequencies of grade 3 adverse events as seen by the orange bars. The blue bars represent any other or mild adverse event reports of local and systemic events. The most frequent overall local reported adverse event was pain, and the most frequent overall systemic adverse events were fatigue, headache, and myalgia. Reactogenicity data were consistent with results from the initial phase 3 program. Duration of symptoms was brief and did not exceed 2 to 3 days. Here are the results of the unsolicited adverse events, or AEs, serious AEs, fatal SAEs, and PIMDs. There was a low frequency of grade 3 events reported across all groups, as depicted in the yellow bars on the left, which were unsolicited adverse events within 30 days. Adverse events within 30 days were comparable across all groups, and there was a short median duration for most adverse events. Safety data were consistent with results from the initial phase 3 program. To summarize these results, the study presented today met the non-inferiority success criteria in adults 50 to 59 years of age with and without comorbidities associated with an increased risk of RSV-LRTD compared with adults 60 years of age and older. Although there is no established correlative protection, the robust humoral and cellular immune-mediated response observed among adults 60 years of age and older after vaccination has been shown to lead to high vaccine efficacy in this group. Thus, looking at the humoral response in adults 50 to 59 years of age, including those with and without comorbidities, compared to the 60 years of age and older age group, vaccine efficacy can be inferred. For reference, results from the pivotal efficacy study are shown here. And lastly, the safety profile for the 50 to 59 years of age group with and without comorbidities is consistent with those in adults 60 years of age and older. Now, I would like to provide a safety update on RSV, starting with an important update on reported cases of ADEM from one of our earlier flu co-administration studies, as well as information on post-authorization safety. The number of ADEM reports in the GSK safety database is now at 0. We are pleased to report that over 2 million doses of RSV have been administered as of October 13th in retail settings in the US. This does not account for doses administered in non-retail settings and outside of the US, and therefore is an underestimate of doses administered globally to date. Reported adverse events reflect the known safety profile of RSV, and we will continue to monitor the safety of this vaccine using all the available surveillance systems. To close, severe RSV disease among adults 50 to 59 years of age with certain comorbidities presents a significant unmet medical need. Study 018 provides data to address this medical need and shows comparable immunogenicity to those 60 years of age and older, inferring vaccine efficacy. RSV is well tolerated with a favorable safety profile in the 50 to 59 years of age group. GSK is committed to protecting individuals at risk for severe RSV disease, ensuring that all adult populations have access and improving health equity. As such, and based on these results, we'll be seeking an indication with the FDA. Thank you for your time, and we're happy to address your questions.
Thank you. This presentation is now open for questions. Dr. Talbot.
Thank you. I wanted to applaud you for enrolling people with comorbid conditions. It's a shame that that was not done in the 60 plus. If you notice the number of comorbid conditions enrolled in the 60 plus, it was much, much lower than what you did in the 50 to 60-year-olds. The non-inferiority is an interesting discussion because it is a pre-specified number, which might have meaning if we had a correlate of immunity. But we don't. And if you look at the graph that you showed with the patients with comorbidity, there's definitely a lower response. And that concerns me since we don't have a correlate of immunity. I'm also a little frustrated because there was no mention of those with immune suppression. We really worry about this in our COPD, CHF, and immune compromised patients. And those would have been really nice numbers to see. And I think it would have had much more meaning to do a randomized controlled trial with efficacy as an endpoint because that population has such a high risk of RSV, and we would know if it worked or not. These are not cheap vaccines. We need methods to protect, and we need to know if they work in these populations that are at highest risk. So I'm glad you finally enrolled patients with comorbid conditions, but I do have to say I'm very disappointed that there was not a randomized control trial. There weren't immunocompromised patients. There was no data on what those comorbid conditions were, because if it's hypertension, it doesn't really mean very much. So I'm hoping in the future that we will see some randomized control trial data with efficacy. Thanks.
Thank you for your question. I would like to just briefly bring up inclusion criteria in this trial for adults 50 to 59 years of age with comorbidities. There were criteria for chronic pulmonary diseases, chronic cardiovascular diseases, and endocrine and other diseases in the 3 boxes on this slide. I would also like to bring up that we did enroll people with comorbidities in our pivotal efficacy trial, approximately 39%. And I do want to say that the proportion of people with comorbidities was 37.7% in this trial, which is similar to the 39%. Thank you. Go ahead.
This is Dr. Leonard Frieda from GSK. Thank you, Dr. Talbot, for your comment. Although we didn't present the values for the geometric mean titers with the group 50 to 59 with and the group without underlying comorbidities, indeed, the numerical values of the GMTs in those with the underlying comorbidities is actually numerically higher than the group who did not have comorbidities. Now, there was no formal statistical testing compared to those 2 groups, but the GMTs were certainly a little even bit numerically higher in those with the underlying comorbidities. Importantly, non-inferiority was met for both groups compared to those 60 years of age and older, in which vaccine efficacy has been demonstrated.
Thank you. I mean, I think being able to see those data would be really helpful. Dr. Paling.
So I wanted to ask, could you clarify what the placebo was, please? And I've got a second question after that.
This is Dr. Leonard Freeland again. The placebo was a saline. I would like to respond to what Dr. Talbot's question about immunocompromised patients. Just to bring up, right now we are currently enrolling a study up on clinicaltrials.gov in adults over the age of 50 who have solid organ transplants for kidney disease and lung transplants, and we just started enrolling down to age 18 in that immunocompromised study.
Okay, thank you. That's important and appreciated.
And this is Camille Cotton. Again, that's just an immunogenicity study, right? You're not planning any real trials of, RCTs or anything that would show any type of clinical protection, right?
The study that I mentioned is an immunogenicity and safety study.
May I ask my second question, please?
Yes, please.
So the second question on slide 19, we're talking about unsolicited adverse events. And I believe the PIMD stands for potential immune-mediated diseases. Would you please, I don't remember hearing that. Would you please describe what you observed in this study? Thank you.
Yes, this is Peggy Webster with GSK Vaccine Safety.
Can't hear.
Can you get closer to the mic? It's hard to hear you.
Oh, I'm sorry. Okay, thank you. Is that better?
Yes.
Yes, ma'am.
Okay, thanks. This is Peggy Webster with GSK Vaccine Safety. And if you give me just a moment to pull up that information, what we saw though with, what I can say with PIMDs is that the rates were extremely low in both of the groups that were evaluated. There were, very few PIMDs, 8 in total, which is less than 1% across the study arms, of which only 3 were serious. There was no clustering of the specific events that were described.
Could you please describe the 3 serious
Yes, we had a case of pericarditis, a case of gouty arthritis, and 1 event of cold-type hemolytic anemia.
Okay, and then can I just ask for clarification, did you see any Guillain-Barré?
We did not see any Guillain-Barré in this study.
Thank you.
Welcome.
Dr. Sanchez?
Thank you for that presentation. I have 2 questions. One of them, you mentioned that 2 cases, the unconfirmed cases of ADEM. Were those from the original trial? So the original cases in the original trial, randomized clinical trial, so those would have been less, if I remember correctly, there were 3 or 4 of them?
This is Peggy Webster again. Those cases were from one of the original trials that was evaluating RSV given in co-administration with influenza vaccine. We had 2 cases of ADEM that were initially reported that have now been reclassified as the diagnosis has been clarified.
And so in the randomized clinical trial, that there were 3 cases in the placebo versus in the vaccine group versus placebo. These are not those cases.
In the randomized clinical trial, there were no cases of ADEM reported.
Okay, thank you. And then among the comorbidity patients, I would imagine that many of them received chronic steroids or other potentially immunosuppressive medications. Do you have any data on any of those patients and whether it affected the immunogenicity?
Thank you for that question. Exclusion criteria included immunosuppressive or immunodeficient conditions, and that also included exclusion of those participants who may have been obtaining chronic administration of immune-modifying drugs for at least 14 consecutive days. So those particular patients would have been excluded from this immunogenicity analysis.
Thank you.
And before we go to Dr. Kimberlin, may I just clarify, they were determined not to be ADEM cases. What did they end up being?
Peggy Webster again, yes. So one of the cases ended up being reported as hypoglycemia plus dementia. And the other event was updated to cerebrovascular accident or a stroke.
Thank you. Dr. Kimberlin?
David Kimberlin, AAP Red Book. Do we have any data on duration of immunologic benefit and potentially an impact of a second dose X number of years down the road? And the reason I ask is I'm kind of thinking if you have one shot with one dose and that's it, you might reach a different conclusion as to when that should be administered age-wise versus if it could be re-administered every 5 years, for example.
Thank you very much, Dr. Kimberlin. Leonard Friedland, the Medical Affairs at GSK. We do have data as presented at the June ACIP meeting, and is that one dose of RSV provides durable efficacy against RSV-associated lower respiratory tract disease for 2 full RSV seasons. And this is protection against severe RSV disease and also in adults with underlying comorbidities. Now, our plans are to continue to follow up the patients from that pivotal efficacy study, which we call Study 6, for a 3rd season, and also to collect data from an additional phase 3 study, which is going to assess the long-term immunogenicity, as well as the immune response following different revaccination schedules. And the totality of this collection of data will then guide our next actions to help inform the most optimal timing for revaccination.
That's Pfizer's.
Thank you. We'll go to Dr. Long, Dr. Paling, and then we'll move on to the next presentation. So Dr. Long.
Let me be sure that I have this correct regarding numbers and Dr. Paling's question about neuroinflammatory events. It looks like there were probably about 720-something adults who received this vaccine in this trial. So that's an extremely small number. We're relieved that there weren't, but it doesn't tell us too much. And the other is a question, am I correct that the FDA has continued to include these 3 cases that you have thought had different explanations?
Peggy Webster with GSK Vaccine Safety. So those 3 cases, the 2 initially reported cases of ADEM plus the initially reported case of Guillain-Barré syndrome do continue to be reflected in our product information.
Thank you.
Dr. Paling.
I want to just say one other thing that was very confusing to this work group and also would be to this group is that the method of presentation of non-inferiority is the opposite direction than we're used to. So that's why there is confusion. So in fact, in the way that it was calculated by GSK and presented to you, numbers less than 1 would indicate on the way to superiority rather than inferiority. And we are used to thinking of less good as less than 1. So that's why it has been confusing. Sorry for that for them.
Thank you. Dr. Paling?
Thank you. One of the important comparisons is the study results from 50 to 59 versus 60 and older. Would you remind us of the age group for the 60 and older, please? And then I have one more question.
Certainly. Thank you very much. Please pull up slide 11. Here is the breakdown of the 60-plus-year-old age group. And as you can see, slightly over half were 60 to 69 years of age, and 34% 70 to 79, and 12.8% 80 and above. Thank you.
Okay, great. And I'm so glad you put this slide up because I want to make a comment. First of all, for everybody that's listening, these studies are hard and it takes a lot of work to do these studies. At the same time, we learned through COVID that you can enroll diverse persons, as you've demonstrated with your comorbidities. You began the conversation talking about the disparities, and so I just wanted to highlight it's really important that we have racial and ethnic disparities, and it's 3% for Black and 0.6 for American Indian and Alaskan Native. And so in the future, I think it's really important that we pay close attention and have it reflect the U.S. population. Thank you.
Thank you very much. This is Dr. Leonard Friedland. The results shown are across the 8 countries in which all subjects are enrolled. We'd be happy to follow up with the U.S. demographics in the future. I did want to follow up in response to Dr. Long, and thank you for bringing up the way that the non-inferiority ratios were shown. Just to mention that the statistical success criteria for non-inferiority that's commonly used for regulatory purposes and happens to be the standard across GSK's analysis plans is a 1.5-fold non-inferiority ratio for the geometric mean titers. Now, mathematically, the numerator and denominator can be inverted. In that case, the success criteria would be a 0.67 lower limit non-inferiority margin, as is shown here on this slide. And as you can see, if we invert the ratios as you were recommending, non-inferiority is met for the GMT ratios, as is when we show it the way that we did.
Thank you. Dr. Lair, last question.
Could you go to your slide that said safety update? If I recall correctly, you said something, you've had 2.2 million doses, and I thought I heard you say that you've had no neuroinflammatory events, and I want to see if that's correct and what you're basing that on, because there should be some neuroinflammatory events out of 2.2 million people. There's a baseline rate.
Peggy Webster with GSK Vaccine Safety. So it is correct, we've had more than 2.1 million doses of RSV that have been administered in the United States. We have had a conversation with the CDC recently where we were informed of cases of neuroinflammatory type events. We GSK have very little information about these reports at this time, and so I can't comment further on them, but we have been informed by the CDC that there are some events.
Could you go to that slide? I think it's a little bit premature to possibly be saying reported AVEs reflect known safety profile when you don't have that information, and to present that to us with that clear a statement. So that's just my opinion. Thank you.
Thank you for that comment.
Okay, Dr. Cotton, Dr. Talbot. I've been labeled no break race, and it's going to be that again. So I'm just going to warn you. Go ahead, Dr.
I actually
Cotton.
have a follow-up for Dr. Layers, which is real quick. There's actually an asterisk next to administered. What does that mean? Does that mean those are the vaccine doses distributed or vaccine doses that are actually put in the arms?
Dr. Leonard Friedland here. Those are doses put into arms as far as we know from our data in retail settings. We mentioned that this does not include non-retail settings and also outside of the United States. So that's an underestimation of the number of people who have received the vaccine in their arm.
Thank you.
And Dr. Cotton?
So I'd just like to go back to Dr. Kimberlin's point where we don't have any data showing a booster effect. So for people who are 50 to 59 years old, will this be a one and done vaccine and we won't be able to give an additional dose of vaccine in a meaningful way, say 5 years later? And I worry that without data supporting kind of long-term immunogenicity, that we actually could be doing harm by giving this vaccine, say, earlier than when they really might benefit from it. So perhaps we should hit pause and wait for some data on boosting. And if there is no boosting, what are we going to do about that situation? I'm sort of thinking for the patients that I care for about aiming this for, their more vulnerable period rather than just, in their 50s with comorbidities, because I am hoping that they would live optimally 1, 2, 3 more decades after that, during which time they may not have RSV protection. So I really remain quite concerned about that. Similarly, Dr. Paling's point is very good about, we know that people of color develop severe hospitalized RSV much younger than whites and Asians. And so it would seem that in doing this trial, the trial would have focused on that high-risk population. But nonetheless, it looks like it was over 80% white. So that's not really helpful information for us trying to figure out who should get this vaccine. Thank you.
Thank you, Leonard Friedland. We'll come back to the committee through the work group with the demographics of the breakdown and those enrolled in the United States. With regards to durability of the vaccine, we do know currently that 1 dose of RSV provides protection against LRTD, severe LRTD, and LRTD in those with underlying comorbidities for at least 2 full RSV seasons. We continue to gather data through all of our clinical trials, and the collection of these data will continue to inform the most optimal timing for revaccination. And while we've been speaking, actually, my team has been able to pull up the percentage of people who were Black in our clinical study that was presented today, and it was 8.5% of those enrolled in the United States were of Black race.
Could you clarify as to why that number was low?
8.5%. I think that's fairly standard for our clinical trials and fairly representative of what we've been able to enroll in our clinical trials in the United States.
Well, it would seem that if it's an at-risk population, that you'd want more data on the at-risk population.
Yeah, I think it's a plea for really addressing health equity at the clinical trial stage, and especially because some of our recommendations are really focused on mitigating disparities that exist. So more reflective of the proportion of the U.S. population that represents Black, Hispanic, other race and ethnicity, I think is the point that we would like to make to all manufacturers, including GSK. But the more you can do for that, the more we can look at recommendations with an equity lens and actually provide additional augmented recommendations. So I think
thank you. Actually, as you've been speaking, since I didn't have this data in front of me to begin with, the team just showed me that actually 14.8% of those enrolled in the clinical study in the United States were of Black race.
Thank you. If you can share that data with the work group, I think that would be really helpful going forward, particularly for the equity domain. We need to move on to the next presentation by Dr. Monica Patton from CDC on the epidemiology of RSV hospitalization in adults, with a focus on adults 50 to 59 years of age.
Thank you. Next slide, please. So today I'll be discussing data from the RSV-associated hospitalization surveillance network, or RSV-Net, which is one of 3 platforms that comprise the RESPNet surveillance system. COVID-Net and FluSurvNet, the other 2 RESPNet platforms, which use very similar surveillance methods, will be used in 2 slides later to provide comparisons between RSV, COVID, and flu-associated hospitalizations. As a reminder, RSV-Net conducts active population-based surveillance of laboratory-confirmed RSV-associated hospitalizations from more than 300 acute care hospitals in 58 counties across 12 states. The RSV-Net catchment area includes about 8.6% of the U.S. population. Hospitalizations reported to RSV-Net include all those where a positive RSV test result was reported within 14 days prior to or during hospitalization. Testing for RSV is driven by clinical judgment and facility policies. Data on rates and basic demographic data are collected on all patients, and clinical data are collected from an age and site stratified random sample. Next slide, please. And while the focus of today's presentation is on the epidemiology of RSV-associated hospitalizations among adults aged 50 to 59 years, I wanted to highlight the other age groups that will be presented throughout today's presentation, which include stratification of adults in RSV-Net into groups comprised of persons aged 18 to 49 years, which is the youngest adult age group, 50 to 59, 60 to 64 years, where 60 is the youngest age recommended for the RSV vaccine with clinical decision-making in the United States, 65 to 74 years, where 65 is the common definition of older adults and is used for a number of other vaccine recommendations, and 75 years or older, where 75 is the age recommended for RSV vaccine in the United Kingdom. Next slide, please. So today we will be focusing on the epidemiology of RSV-associated hospitalizations among adults 50 to 59 years in comparison to other adult age groups, including reviewing demographics of persons hospitalized with laboratory-confirmed RSV, rates of RSV-associated hospitalizations, underlying medical conditions amongst hospitalized adults, and severe outcomes among hospitalized adults, including ICU admission, receipt of mechanical ventilation, and in-hospital death. Next slide. So overall, during the 9 seasons between 2014 to 2015, and the most recent 2022 to 2023 season, there were 17,847 RSV-associated hospitalizations captured among adults aged 18 years or older. Among those hospitalizations, approximately 14% occurred among adults aged 50 to 59 years. In total, 62% occurred among white persons, 20% among Black persons, 8% among Hispanic persons, 6% among Asian or Pacific Islander persons, and 0.5% among American Indian or Alaska Native persons. Next slide, please. To review evidence related to RSV-associated risks by age, here are seasonal rates of RSV-associated hospitalizations among U.S. adults, stratified by 5-year age groups. These are estimated from RSV-Net during 5 RSV seasons before the COVID-19 pandemic. Rates shown here have been adjusted for frequency of RSV testing each season, as well as sensitivity of the RSV diagnostic test used. You can see that RSV-associated hospitalization rates increase with increasing age and were lowest among adults 18 to 49 years and substantially higher among adults 85 years or older as compared with other age groups. RSV-associated hospitalization rates range from 23 to 42 per 100,000 population among adults 50 to 54 years, and from 26 to 59 per 100,000 population among adults 55 to 59. Next slide. Here we see rates of RSV-associated hospitalizations from the most current 2022 to 2023 season. Of note, these rates have not been adjusted for RSV testing practices and underestimate the actual rates of RSV-associated hospitalizations, as not all people hospitalized with respiratory illness are tested for RSV, and clinician-driven testing practices may differ based on patient characteristics such as age or disease severity. In these data, rates of hospitalization among adults 50 to 59 are denoted in the blue line that is the second from the bottom. And similar to the previous slide, we see that rates of RSV-associated hospitalizations increase with increasing age. Next slide. In RSV-Net, among adults hospitalized with RSV, almost all, or 94%, had at least one underlying medical condition, with more than 60% of adults having 3 or more conditions. Next slide. Cardiovascular disease, obesity, diabetes, COPD, and heart failure were the most frequent underlying medical conditions among adults hospitalized with laboratory-confirmed RSV. It is important to note that these conditions occurred among patients who had clinician-directed testing, and patients with underlying medical conditions may have been more likely to be tested for RSV than those who did not have underlying conditions. However, even with this consideration, these data suggest that the proportion of patients hospitalized for RSV who have comorbid conditions is very high. Next slide. This graph depicts the most frequent underlying medical conditions among adults hospitalized with laboratory-confirmed RSV by age group. The conditions are listed in rank order from most frequent to least frequent among patients who are 50 to 59 years. Next slide. We can see that approximately 14% of adults 18 to 49 hospitalized with RSV had no underlying medical conditions, compared to only 4% of adults 50 and older. Next slide. Conversely, 86% of adults aged 18 to 49 with RSV-associated hospitalizations had at least one underlying medical condition, and almost all adults 50 years and older had at least one underlying medical condition. Next slide. And when we further quantify the number of medical conditions, we see that the proportion of patients with only one or two medical conditions decreases with increasing age. 44% of adults 18 to 49 years hospitalized with RSV had only one or two underlying medical conditions, compared to 38% of adults 50 to 59 and only 26% of adults 75 years and older. Next slide. Conversely, the proportion of patients with 3 or more underlying medical conditions increases with increasing age. Among adults 18 to 49 years hospitalized with RSV, 42% had 3 or more medical conditions. 58% of adults 50 to 59, but nearly 70% of adults 65 and older had 3 or more medical conditions. Next slide. When we look at the most prevalent medical conditions by age group, obesity is the most prevalent underlying medical condition for adults aged 18 to 49 and 50 to 59. And for adults 60 years and older, cardiovascular disease is the most prevalent underlying medical condition. Next slide. When looking at the second most prevalent underlying conditions among adults hospitalized with RSV, we see that asthma was the second most prevalent condition for adults 18 to 49 years, cardiovascular disease for those 50 to 59, obesity for 60 to 64 and 65 to 74, and heart failure was the second most common condition for adults 75 years and older. Next slide. And lastly, to round out the top 3 most prevalent underlying medical conditions for adults hospitalized with RSV, we see that immune-compromising conditions are the third most prevalent condition for adults 18 to 49 years, diabetes for adults 50 to 59 and 65 to 74, COPD for adults 60 to 64 years, and COPD and chronic kidney disease for persons 75 years and older. These data suggest that underlying conditions that may put adults at increased risk for hospitalization for RSV differ by age, with different profiles occurring among the youngest adults in the 18 to 49 year group and among the oldest group, who are 75 and older. Next slide. So in the previous slides, we looked at underlying medical conditions among persons with laboratory-confirmed RSV hospitalizations by various age groups. To help contextualize these data, here we see the prevalence of certain medical conditions in the general population, as captured from the National Center for Health Statistics, and among patients hospitalized with laboratory-confirmed RSV. We have adults 50 to 64 on the left and adults 65 and older on the right. And while this is not a comparison between the exact age groups that we reviewed today, we can see that coronary artery disease, COPD, diabetes, and asthma are overrepresented among hospitalized adults in RSV-NET compared to the prevalence in the general population. With those conditions being 2.7 to 5.7 times more prevalent among adults 50 to 64 hospitalized with RSV compared to adults of the same age in the general population, and 1.6 to 3.4 times more prevalent among adults 65 and older hospitalized with RSV compared to adults of the same age in the general population. Of note, obesity appears to have similar prevalence among adults hospitalized with RSV and among adults in the general population. Next slide. Here we see a comparison of only adults 50 to 59 years with RSV-associated hospitalization on the right of the slide, and among those who are admitted to the ICU on the left of the slide. Next slide. And when we compare the prevalence of underlying medical conditions amongst adults 50 to 59 who were hospitalized with RSV to those who were admitted to the ICU, most medical conditions were more prevalent or increased in rank order among adults admitted to the ICU, as shown here in red. For example, cardiovascular disease occurred among 43% of adults 50 to 59 years admitted to the hospital, but among 49% of those admitted to the ICU, and moved from the second most common underlying medical condition among hospitalized adults, 50 to 59, to the most common underlying condition among those admitted to the ICU. Similarly, heart failure and chronic kidney disease were more prevalent among ICU patients than hospitalized patients and increased in rank order among ICU patients. Next slide. Conversely, there are 5 medical conditions that demonstrated the same or decreased prevalence among adults 50 to 59 admitted to the ICU with RSV as compared to those who were hospitalized with RSV, including obesity, asthma, chronic metabolic disease, blood disorders, and autoimmune disease. Next slide. The last few slides have talked about characteristics that may increase risk for severe RSV disease. Overall, however, among all adults hospitalized with RSV, a large proportion are severely ill, as measured by the proportion admitted to the ICU, the proportion who received mechanical ventilation, and the proportion who died in hospital. In these RSV-NET data from over the most recent season, we see that about 21% of hospitalized adults 50 to 59 years were admitted to the ICU, approximately 10% received mechanical ventilation, and 3% died while in the hospital. Across all the age groups, the mortality was highest in those 75 years and older at 6%. However, note that the proportions admitted to the ICU were similar across all the age groups, ranging from 15% to 21%, reflecting that younger adults hospitalized with RSV experienced similar rates of severe outcomes as older adults. Next slide. This figure provides comparisons of data from adults hospitalized with laboratory-confirmed RSV, influenza, and COVID-19 using data from RSV-NET, FluServ-NET, and COVID-NET. And these are for the most recent 2022 to 2023 surveillance season. Note that active surveillance for FluServ-NET for the most recent season occurred during a typical respiratory virus surveillance season of October through April, whereas both RSV-NET and COVID-NET surveillance occurred year-round. This figure compares proportion of adults with RSV, influenza, and COVID-19 associated hospitalizations who were admitted to the ICU by age group. The proportion of adults of all ages hospitalized with laboratory-confirmed RSV, influenza, or COVID-19 who were admitted to the ICU were equivalent across the 3 pathogens, indicating that RSV infection in adults may be as severe as influenza and COVID-19 infections in adults. Note that these proportions only include ICU admissions amongst adults hospitalized with laboratory-confirmed RSV, influenza, or COVID-19, and do not take into account RSV testing practices or vaccination or treatment status of patients. More severely ill patients may be more likely to have been tested for RSV, influenza, or COVID, which may overestimate the proportion of hospitalized patients that were admitted to the ICU. Additionally, these data don't take into consideration a patient's vaccination status, and we know that recent publications have demonstrated that patients vaccinated for influenza or COVID-19 are less likely to require ICU admission. Next slide. This figure provides comparisons of in-hospital deaths from adults hospitalized with laboratory-confirmed RSV, influenza, and COVID-19, using data from RSV-NET, FluServ-NET, and COVID-NET for the most recent season. And similar to patterns seen in the last slide, the proportion of adults of all ages hospitalized with laboratory-confirmed RSV, influenza, or COVID-19 who died in hospital were similar across the 3 pathogens, again indicating that RSV disease in adults is as severe as that of influenza and COVID-19 disease in adults. Next slide. This demonstrates the distribution of all adult RSV-associated hospitalizations by age group for the most recent season. Hospitalizations among adults 50 to 59 years comprised 12% of all hospitalizations captured in RSV-NET during the most recent season. Next slide. Similarly, when we look at the distribution of all adult RSV-associated ICU admissions by age group, ICU admissions among adults 50 to 59 years comprise 14% of all ICU admissions captured in RSV-NET. Next slide. And adults 50 to 59 comprise 22% of all hospitalized adults who required mechanical ventilation in the most recent season. Next slide. And lastly, adults 50 to 59 comprise 9% of all adult in-hospital deaths for the most recent season. Next slide. Turning now to look at RSV-associated hospitalizations by race and ethnicity. Next slide. The median age of white patients and Asian or Pacific Islander patients at 73 years was higher than that of patients who were Black, 62 years, Hispanic, 62 years, or American Indian at 64 years. Next slide. The proportion of hospitalized adults whose race was reported as Hispanic or Black decreased with increasing age. Black adults accounted for 29% of hospitalized adults aged 18 to 49 years, and 7% of those aged 75 years or older. And Hispanic adults represented 18% of hospitalized adults aged 18 to 49, but only 5% of those aged 75 or older. This likely reflects different age distributions and life expectancy by race and ethnicity within the catchment population, as well as potentially higher risk for hospitalization among Black and Hispanic persons at younger ages, resulting from racial and ethnic disparities and underlying medical conditions, access to medical care, or socioeconomic status. Next slide. Similarly, the proportion of Black adults with RSV-associated hospitalizations who were admitted to the ICU decreased with increasing age. Black adults accounted for 39% of adults aged 18 to 49 years admitted to the ICU, and 9% of those aged 75 years or older. Next slide. Lastly, we're going to review rate ratios of RSV-associated hospitalization rates stratified by race and ethnicity among each age group. Rate ratios are calculated by dividing the hospitalization rate of one group by the hospitalization rate of a reference group in order to assess the magnitude of difference between the two rates. For these data, white adults serve as the reference group and are indicated here in blue with a rate ratio of 1 at each age group. Rate ratios that approach 1 have hospitalization rates that are about the same as the reference group. Rate ratios greater than 1 indicate the rates that are that many times higher than the reference group, and rate ratios less than 1 indicate rates that are that times lower than the reference group. And for each group, the rate ratios data will be presented as the average rate ratio across 4 pre-pandemic RSV seasons from 2016 to 2017 through 2019 to 2020, with the error bars indicating the maximum and minimum rate ratios across the seasons. RSV hospitalization rates displayed here have been adjusted for frequency of RSV testing practices each season, as well as for the sensitivity of the RSV diagnostic tests used. Next slide. And here we see the average, minimum, and maximum rate ratios among Hispanic adults in teal compared to the reference group. Across all age groups, hospitalization rate ratios for Hispanic adults are close to 1, indicating that laboratory-confirmed RSV hospitalization rates among Hispanic adults across all age groups were similar to those among white adults of similar ages. Next slide. These are the average, minimum, and maximum rate ratios among Asian or Pacific Islander adults compared to the reference group in teal. Across all age groups, hospitalization rate ratios for Asian or Pacific Islander adults are less than or close to 1, indicating that laboratory-confirmed RSV hospitalization rates among Asian or Pacific Islander adults were similar to or slightly less than hospitalization rates among white adults of the same ages. Next slide. And sorry, it wasn't in teal, it was in gray. And here we see the average minimum and maximum rate ratios among Black persons compared to the reference group in yellow. Among Black adults 18 to 49 years, hospitalization rate ratios range from 1.5 to 2, indicating that laboratory-confirmed RSV hospitalization rates among Black adults 18 to 49 years were 1.5 to 2 times higher than hospitalization rates among white adults of the same age. Among Black adults aged 50 to 59 years, hospitalization rate ratios range from 1.7 to 2.4, indicating that laboratory-confirmed RSV hospitalization rates among Black adults were aged 50 to 59 were 1.7 to 2.4 times higher than those among white adults of the same age. As age increases, hospitalization rate ratios for Black persons moves closer to 1, indicating similar hospitalization rates between older Black and white adults. Next slide. Lastly, average, minimum, and maximum rate ratios among American Indian or Alaska Native persons compared to the reference group is indicated in purple. And similar to patterns seen among Black adults, hospitalization rate ratios among American Indian Alaska Native adults are 2.5 to 3.9 for adults 18 to 49 years and 1.9 to 3.3 for adults 50 to 59, indicating that laboratory-confirmed RSV hospitalization rates among younger American Indian Alaska Native adults was approximately 2 to 4 times higher than hospitalization rates among white adults of the same age. And as age increases, hospitalization rate ratios for American Indian Alaska Native persons move closer to 1, indicating similar rates between older American Indian Alaska Native and white adults. Next slide. And thanks to everybody who was involved in sharing these RSVNet data. That was my last slide. Thank you.
Thank you. This presentation is now open for questions. Dr. Paling.
So first of all, thank you for this great presentation. I appreciate and recognize how hard it is to get hospitalization data on adults. My question for you is, in the RSV net, do we know what percentage of the adults are tested during the hospitalization with respiratory illness? Thank you.
Thanks. We know that for the first few seasons that I showed you. So if we look at slide number 6, please. So when we calculate rates, these are actually adjusted for the persons who are tested for RSV, and we do that by collecting all RSV tests that were done in those hospitals. And that's actually the reason why we only show these data for the pre-pandemic seasons, because those are the only years that we have those data to be able to adjust the rates for RSV testing practices.
Okay, Dr. Brooks.
Yes, 2 comments. One, on slide 23, we have the hospitalization rates. So first of all, it's really nice to know that 3 years ago, 2 of these 3 there were no vaccines for, and now there are. But we tend to think of COVID as having a higher level of morbidity and mortality, but I think this slide is very compelling to show that RSV and flu and COVID are similar. Some of it may be due to the high vaccination rate and infection rate of COVID. And the other comment is that as the African Americans cross to less than 0 in terms of the rate as with age, I wonder if some of that actually has to do with life expectancy, and that as African Americans have a lower life expectancy, so it just may be a lower percentage in the population that will even be alive to get RSV as you get to that age group of 75 and up. I think it was like your last slide or next to the last slide that showed the crossover. So just as a thought.
Yeah, thank you. That we definitely think that has something to do with that. And as we increase in age, certainly the numbers become less, the numbers become lower. And so that could be playing a role in that.
Thank you.
Dr. Long?
Yes, as we're thinking about how we might implement some kind of targeted use of vaccine in younger people, we don't want to misunderstand any of these things. So the question really is, although it is important to know racial characteristics of hospitalized people, is that really a racial characteristic? Is it a marker for underlying conditions, or is it a marker for how people live and their exposures? So do we have any way that we can tease apart? So is it possible that we wouldn't want to say that we should target Black people with this vaccine if in fact any other group who had similar underlying conditions would have similar rates of hospitalization and severe disease. So is there any way that we can separate any of these things and see if there is residual risk that is associated with race that still might be a marker not for racial predisposition to severe RSV, but might be the likelihood that they would be exposed to small children or be crowded or have pollution in their environment, et cetera. Can you separate any of those things?
We don't have those data right now. One thing we can do in RSVNet is look at underlying medical conditions by age and by race, and that is not something that we presented here today. So some of the, the increased rates among certain populations may be due to increased number of medical conditions, and we can certainly put that together and share that with the work group.
Dr. Lehr?
Thank you. For this slide that we're on, 23, it's got the percentages for RSV, flu, and COVID. I'm just checking, does that mean that they were admitted to the intensive care unit and they had a positive RSV, but not flu and not COVID? Or is there a chance that they might have had 2 out of the 3? Because that would change my perspective.
This could include co-infections. There were not a lot of co-infections, but this certainly could include some co-infections in those numbers. Importantly, this does not include vaccination status, so it may be that we are not looking at patients who were not admitted to the ICU because they were vaccinated, and so we don't have those data now, but we could certainly share that data with the work group.
Thank you.
Dr. Talbot?
Yeah, to Dr. Lehr's point, we were talking over here, I think the 50 to 59-year-old that's in the ICU are more likely to get tested for RSV than on the wards. If on the wards and they're stable, you do less of a workup. When they hit the ICU, you start doing all these tests. And so I think there may be a little bit of a bias of increased testing in the ICU. I still think RSV is an incredibly severe disease and puts many people in the ICU. I wanted to go back to slides 8 and 18. You can do either way. So this is number 8. Look at the number of people with comorbid conditions. This is not what we enroll in our clinical trials in older adults. I think this is critically important that we start mirroring the population that gets sick. This is crucial. And then 18. And this kind of shows you what we're talking about. I think if we're going to start talking about at-risk recommendations, which probably we should do for those 60 and over, but we'll come back to that. Those 50 to 59 that we want to do at risk, these are the patients we need to have data on. And so I just want to reiterate the fact that it's incredibly helpful if what is enrolled looks like what we want to target the vaccine for. It gives us much greater confidence in the use and the spending of that money. To put it in a pediatrician's terms, it is like testing a vaccine in a 5-year-old and then using it in infants. We don't do that for a reason, because they're not the same. And so I think it's critically important not only to get vaccines for adults, but also when we have vaccines for adults, we test them in the adults that we think need it. Thank you.
Dr. Daly?
Could you go to slide, I think it's 8, it's back to chronic medical conditions. Of those with 1 to 2 conditions, what proportion of those have obesity? And I guess my question is sort of what's our broader interpretation of what was the work group's interpretation of sort of this slide with respect to sort of ability to identify those who are at increased risk of RSV based on comorbidity? Thanks.
I'll just say that we can take obesity out of these and provide those data to the work group if that would help provide some clarification. We do not have that right now, but that is something that we can do.
Yeah, and it wasn't, the reason I mentioned that specifically is just because I think of those, it's the most prevalent condition. So yeah, thank you.
One thing that we did talk about in the work group is obviously these are among people hospitalized for RSV, and they're not rates among risk conditions, and that is something that we are going to try to work on with the RespNet data. The issue is that we don't have, from the catchment area, the risk conditions identified. We have general population, so we have to kind of go back and do another analysis, and that is something that we're working on. So.
Thank you. Let's please move to the next presentation. Dr. Amadea Britton, Work Group Interpretations.
Good afternoon. My name is Amadea Britton, and I serve as the CDC co-lead for the Work Group for Adult RSV Vaccines, along with Dr. Michael Melgar. Today, our next slide. Today, I will present a summary of the current work of the work group, beginning with the review of the current recommendation for use of RSV vaccines in adults aged 60 years and older. Then I will briefly summarize the safety and immunogenicity data GSK shared today on use of their RSV pre-F3 vaccine in adults aged 50 to 59. And finally, I'll share the work group's preliminary interpretation of these new data and how they are thinking about what this means for upcoming policy decisions. I would like to note that I am not presenting any data today on initial estimates of RSV vaccine uptake or post-marketing safety surveillance data, as we have accrued limited data this early post-recommendation. CDC recognizes the critical nature of these data and will work to publicly share updates as soon as accurate estimates are available. Next slide, please. We will start by briefly reviewing the current recommendation for use of RSV vaccines in adults aged 60 years and older. Next slide. In June, ACIP and CDC recommended the first two RSV vaccines for prevention of symptomatic lower respiratory tract disease, LRTD, in older adults. RSV pre-F3 or Arexvy made by GSK, and RSV pre-F or Abrezvo made by Pfizer. Next slide. In making the decision to recommend RSV vaccines for adults 60 and older, the work group and ACIP reviewed data from large phase 3 clinical trials for both products. In the trials, both RSV vaccines demonstrated significant efficacy against symptomatic RSV-associated LRTD among adults 60 and older over at least 2 seasons. However, they were underpowered to show efficacy in subpopulations at the highest risk and against RSV hospitalization. From these efficacy results, acknowledging the limitations, the work group and ACIP determined that RSV vaccination has the potential to prevent considerable morbidity from RSV disease in older adults. Next slide. In addition, as part of the work group and ACIP's deliberations, they reviewed data on 6 cases of inflammatory neurologic events, including Guillain-Barré syndrome observed in the trials, 3 in GSK's clinical trials and 3 in Pfizer's clinical trials. Of note, 2 of the 3 cases in GSK's trials were reported as acute disseminated encephalomyelitis, or ADEM, in participants that simultaneously received RSV pre-F3 vaccine and standard dose seasonal influenza vaccine. Since FDA licensure, the site investigator that initially reported the cases has revised the diagnosis in both cases from ADEM to hypoglycemia and dementia, and from ADEM to stroke. FDA's package insert for RSV pre-F3 vaccine continues to list these cases as serious adverse events. And I do want to just note here in regards to Dr. Sanchez's question, the 3 cases that we're talking about are the 3 cases we've been talking about all along. They're the cases across all clinical trials, but it's just in GSK they were observed in this co-administration trial, not in the pivotal phase 3 efficacy trial. In Pfizer, the cases were observed in their pivotal phase 3 efficacy trial. But again, these are the same 3 that we've been talking about all along. And then additionally, we noted there was an imbalance in the small number of atrial fibrillation events recorded within 1 month post-vaccination in each of the phase 3 trials. And due to the small number of events, it's unknown at this time whether these events occurred by chance or whether RSV vaccination increases the risk of these events. Next slide. At the June meeting, the work group proposed for ACIP's consideration a universal recommendation for the use of RSV vaccines in those 65 and older with shared clinical decision-making in adults 60 to 64 years. Although this was the work group's majority opinion at the time, there was no unanimous recommendation. During ACIP deliberations, voting members weighed the potential significant public health benefit of the vaccine, especially among those at increased risk, with the existence of a potential safety signal. An amendment was proposed and accepted that all adults ages 60 and older, including both 60 to 64-year-olds and those 65 and older, may receive a single dose of RSV vaccine using shared clinical decision-making. The shared clinical decision-making recommendation was intended to allow flexibility for providers and patients to consider individual risk for RSV disease and target vaccination to those most likely to benefit. Next slide. In the supporting clinical considerations and MMWR for the recommendation, a number of conditions that increase risk of severe RSV disease were highlighted, including lung disease, cardiovascular disease, and moderate or severe immune compromise. These were intended to assist providers in assessing a patient's risk of severe RSV disease. Next slide. Other factors associated with increased risk were also highlighted, including residence in a nursing home or other long-term care facility, frailty, and advanced age. Next slide. Now that we have reviewed the context for the current existing recommendation for those 60 and older, we will turn to the potential use of GSK's RSV pre-F3 vaccine in adults aged 50 to 59 years. Next slide. Today, GSK shared clinical trial data demonstrating that the humoral immune response to a single dose of RSV pre-F3 in adults aged 50 to 59 years was non-inferior to the response in adults 60 and older. Non-inferiority was demonstrated in both 50 to 59-year-olds with chronic stable medical conditions not associated with increased risk of RSV disease, and in adults with conditions associated with increased RSV risk, such as COPD and cardiovascular disease. Cellular immune response also appeared similar across groups, but was not evaluated statistically. The safety profile among age groups was also similar. Next slide. So what do these new data mean for future policy? The non-inferiority data suggest RSV pre-F3 vaccine efficacy in immunocompetent adults 50 to 59 will be similar to the vaccine efficacy demonstrated in the clinical trials among adults 60 and older. The workgroup notes that if FDA licensure is granted for use of RSV pre-F3 in adults 50 to 59, then ACIP will likely need to make a policy recommendation on whether RSV vaccination should be recommended in this new age group, and if so, should the recommendation be the same as in adults 60 and older, i.e. shared clinical decision-making, or is a different type of recommendation preferred? Next slide. The workgroup also expressed a number of concerns around these new data. Immunocompromised adults are known to be at increased risk of severe RSV disease, but were excluded from this and prior trials as discussed. The workgroup also would have preferred efficacy data in this age group, noting that there is no established immunologic correlative protection against RSV disease. Lastly, the workgroup expressed that those with certain risk conditions under 50 are also at increased risk, and immune bridging and ideally efficacy studies in these other age groups would provide important information. And when thinking about use in younger persons, potentially pregnant persons will also need to be considered. Next slide. To close today, I will present the workgroup's preliminary considerations on the upcoming potential policy options. Next slide. First, the workgroup notes that RSV disease is a public health problem in adults aged 50 to 59 years. However, the rate of RSV-associated disease in the general population of 50 to 59-year-olds is less than the general population of adults 60 and older. We saw this in the figure Dr. Patton presented earlier, shown again here, of RSV-associated hospitalization per 100,000 by age. Next slide. The workgroup also notes, however, that while overall rates of severe RSV disease among adults 50 to 59 may be lower, certain medical conditions place people at increased risk of severe RSV disease even at younger ages. As a reminder, in RSV-Net, we saw that certain chronic conditions, including coronary artery disease, COPD, diabetes, and asthma, are overrepresented among people hospitalized for RSV compared to in the general population of 50 to 59-year-olds. Next slide. Lastly, the work group recognizes that there is an important equity component in considering a recommendation for this age group. We know that Black, Hispanic, and American Indian, Alaska Native adults may develop certain chronic medical conditions at younger ages than white adults or experience disparities in other social determinants of health, putting them at risk of severe RSV disease at younger ages. In the red box, I'm highlighting the disparity in hospitalization rates that is more pronounced in 50 to 59 than in 60 plus. Next slide. Taking all this together, the work group is considering multiple policy options that incorporate the potential for licensure of RSV vaccines in adults 50 to 59. Members have stressed that upcoming data on the implementation of shared clinical decision-making, vaccine uptake, post-marketing safety surveillance, and, if available, effectiveness data among those 60 and older will be essential to determine the future preferred policy option, both among 50 to 59-year-olds and among those 60 and older. At this time, the work group continues to believe that a focus on those at highest risk of severe disease is warranted while awaiting post-marketing surveillance data, particularly on inflammatory neurologic events. Next slide. Preliminarily, the work group broadly agrees that the use of RSV vaccine among certain adults aged 50 to 59 years is likely to have public health benefit. Members particularly acknowledge the equity concern of a recommendation for this age group and note that if there is no recommendation and FDA licenses RSV vaccine in 50 to 59-year-olds, insurance will not cover its use, potentially furthering existing disparities. The current priority of the work group is to ensure access to vaccination among adults 50 to 59 and those 60 and older who are at substantially increased risk of severe RSV disease and likely to benefit most. Next slide. On this slide are a range of potential policy options. I'd like to note again that the work group is not yet recommending any of these options, but wishes to share the range of potential options being discussed. Which is the preferred option will depend on incoming data and the full grade and ETR process. At the top of this figure in the red box is the current recommendation. You can see that expanded shared clinical decision-making, along with a number of combinations of risk-based and universal recommendations, are all potential options. Next slide. I'll end here by outlining the work group's planned next steps. Over the next few months, the work group will review post-marketing and observational data as they become available among adults 60 and older. This will include vaccine uptake data stratified by demographic and risk conditions, and vaccine safety surveillance data from VSD, VAERS, and now, as you heard today, VSafe, in addition to other surveillance data. The work group will be particularly evaluating the implementation and implication of shared clinical decision-making. The work group will then develop an updated policy question for RSV vaccination in adults through review of updated grade. Oh, sorry, next slide. I think we're one behind. Yeah, thanks. An updated policy question for RSV vaccination in adults through review of updated grade, updated cost effectiveness analyses, including in those 50 to 59 and stratified by risk conditions, and updated evidence to recommendations. In the coming months, the work group will also begin reviewing safety and efficacy data of a third RSV vaccine, Moderna's mRNA 1345, for use in adults 60 and older. Next slide. The work group would like to close by asking the ACIP members what additional data are needed prior to ACIP voting on updated recommendations for RSV vaccination in adults aged 50 years and older, and also to hear any questions from ACIP as we plan for future policy considerations. Thank you.
Thank you. This presentation is now open for questions. I actually have a couple that I'll start out with while we're waiting for hands to be raised. Regarding opportunities for data, I think obviously we're going to continue to be focused on safety. So, the continual review of information as it's coming in, I think would be incredibly helpful for the work group to review and then share with the committee. As part of that, I'm also going to ask specifically, because we have so many seasonal vaccines now, about concomitant vaccination safety, because I do think that continues to be an area of opportunity for us. And then just like a comment from the earlier conversation, and I'm struggling with this, and I open it up to others to help guide, but I am very much struggling with the importance of equity can't be understated here, going from clinical trials all the way to the recommendations. And I'm struggling a bit with the variety of recommendations on the table because, I'm now starting to think about well, there are disparities that exist. Will our recommendation worsen those disparities or widen those disparities or keep them the same or narrow those disparities? And if we sort of think about it that way, I struggle with sort of the options we have that are easy to implement. Risk-based versus broad recommendations. It's always easier to provide a universal recommendation. Risk-based is both complicated to implement, and I also worry about access to healthcare delivery system and whether or not we're able to identify some of the risk-based conditions in particular. Same with shared clinical decision-making for the same reasons. And then, in COVID, we ended up going lower in age group with less data because we felt just addressing the known inequities was so important. And I was very comfortable with that recommendation, even though we probably had less data than we wanted, in part because the disparities were so clear. For all these respiratory diseases, it's becoming clear to me that the disparities are just baked into the way we're seeing these data. And so I'm struggling with how to think about addressing and mitigating those disparities upfront in a way that's implementable. And for whatever reason, like age is the only thing that comes to mind that's easy, but I feel like we got to find a better way. Sorry, just commentary. You don't have to answer. Dr. Talbot.
I'm on the work group, but I'm going to say this out loud anyway because I can say it. When we looked at the data of re-immunization a year later, the efficacy looked worse and not as good as the first year, which doesn't make physiologic sense to me because with the adjuvant, you should have a T cell response. It should be just as good. So I don't understand the possible blunting. And I think that really, this has been talked about before, and Dr. Cotton talked about it, when and how we use this vaccine, if there's blunting, is going to be incredibly important. And so I think for us to decide 50 and over, we really need to see third doses and fourth doses and really kind of look at what's going on with this. Maybe there should be some animal studies just to kind of figure this out, because I think that has huge impact on how we recommend these vaccines going forward.
I did want to ask if our GSK colleagues had the slides from June available on 004 or 006, because I do have a copy of them, which I can share, but obviously yours would be higher quality. This is we have immunogenicity data of revaccination at 12 months.
Leonard Friedland from GSK. Yes, we have available those slides. Is anything in particular you'd like us to bring up?
Yeah, can you share the 006 like 2-season VE and also the 004 humoral immune data?
Yes, we can. Let's start with 006. We're just bringing it up. Just give us a moment. Okay, we're just getting that slide up. We just have 006 in front of us, but for 006, if we can bring up the slide, can we do that? Just give us a second. But while we do it, I can mention to you that the vaccine efficacy in season 1 for LRTD was 82.6%, for severe LRTD 90. Here it is. Let me just bring this up. It's coming up. Just give us a second. There we go. Okay, so what we're showing here is efficacy against RSV LRTD and RSV severe LRTD as defined in our protocol over the first season and then over 2 full seasons. The median time of follow-up was 18 months after the first dose of vaccine. And rather than repeat the doses, you can see the efficacy, high efficacy against LRTD and severe LRTD over 2 full seasons, including in those who had 1 or more pre-existing comorbidities of interest. And in particular, we show the vaccine efficacy in those who had 1 or more cardiorespiratory disorder of interest and one or more endocrinologic disorder of interest.
Dr. Friedland, I was wondering if you had the season 2 revaccination.
Well, what we have here is season 1 plus season 2. So what happened when people were followed from dose 1 through 2 full RSV seasons. That's what we show here. And is there something else you'd like to see?
Yeah, the revaccination arm. But anyways, to Dr. Talbot's point, yes, it was 55.9% in people that were revaccinated in season 2 and 56.1% in people that had just gotten 1 dose and followed 2 seasons in the second season. So to Dr. Talbot's point, the revaccination efficacy in this trial looked similar.
So what we found, just to remind people from our presentation this past June, is that when a second dose was given 12 months after the first dose, there wasn't any additional benefit in vaccine efficacy. And we looked at our immune response as well when given at 12 months and at times past then. And what we saw, and has been reported in the literature with other pre-F3 antigens, is that the humoral immune response with a dose given 12 months after the first dose does not exceed that when given just with the first dose. So that is why we're continuing to follow patients in our clinical trials through 3 seasons. And we'll be looking at the humoral and cellular immune response when additional doses are given more than 12 months after the first dose. We will have additional data in the future in our clinical trials.
Let's move on to Dr. Paling.
All right, so thank you leave this slide up. All right, so I'm trying to understand what's going on in the studies. Are you going to follow people who received 1 dose through 3+ seasons?
Yes, we are.
Okay. All right, excellent. And then, so thank you. That's my question for you. And then another thing that's really, as I'm thinking about how do we improve the health across the nation and improve equity, having a standardized immunization platform for all adults is important, because remembering whether or not you received something 2 years ago is going to be a really hard thing. And so a question to the is, can that be feasibly done, and can the infant platform be expanded to include adults? Thank you.
I'm going to let that be answered hopefully at a later meeting, because we do have to wrap this up. So I'm going to call on names, and if you could ask your question succinctly, specifically regarding the questions the work group had for us. So we'll go to Dr. Daly next.
Yeah, thanks. I will try to make this as succinct as possible. So my understanding that if we reevaluate the conversation for 50 and over, that would potentially include decisions 60 and over in that conversation. Okay. Yeah, so I will make this brief, but I've just had some discouraging feedback about the shared clinical decision-making in the 60 and over so far. And I'll just list a couple things, then we'll just kind of move on. It entails a long conversation in primary care. The advertising that's been in the public is actually in some ways making that worse because it complicates the conversation when patients who are not at greatly increased risk are coming in and asking for this vaccine. It's hard to develop clinical decision support that sort of supports that kind of decision, and hard to have standing orders. And then we have this fundamental question about duration of immunity that I feel like we haven't answered. So I think those all would apply to a decision 50 to 59, but they would also apply to a decision 60 and over. And I'm not saying we're relitigating that today, but we need to consider all of that as we move forward. And I appreciate I'm appreciative that we have a vaccine for prevention, and I'm also appreciative that the work group is going to continue to look at this, but it's been a challenge. Thanks.
Thank you. Dr. Brooks?
Yes, so for me, I would want to have more comfort with correlative protection in terms of humoral response. And Dr. Long said we don't have that. I'm just noting that we do have efficacy for the 60 plus, and we have what the immune response was, and usually in bridging, you don't have efficacy. So I'm kind of comfortable with accepting the correlative protection that was presented with the non-inferiority today. As it relates to the shared decision-making versus risk-based versus universal, if you think about it, shared decision-making is risk-based. I mean, you're talking to someone, okay, you need this for a reason, and that generally is because you're at risk. So I do not endorse shared decision-making. And lastly, I'll say that for me, with that data so strong with the African-American population, the younger age group, I would feel that that would be an indication in and of itself. There was a statement, well, if you tease out the underlying conditions, et cetera, but there are a lot of studies that show you tease out all of the social determinants of health and even underlying conditions, you still have higher rates in African Americans of many conditions. So I think that there's very compelling data today regarding that. So just last, I'd say either universal or risk-based. At this point, I would say risk-based.
Thank you. Dr. Lair?
So to answer your specific questions, I would ask for a good cost-benefit analysis, because my sense was that the previous recommendation was barely acceptable, and so I imagine it will be not as acceptable, but possibly I'm wrong. And for me to change out of shared clinical decision-making in my practice, I need to be much more comfortable about the neuroinflammatory risks. That is the main thing that I counsel my patients on, and so I need to be comfortable with that. Thank you.
Thank you. Dr. Whitley-Williams?
Thank you, and I'd like to thank the work group for the excellent job that they've done and the presenters. I would ask the work group to look at maybe modeling in terms of how many RSV-related hospitalizations, ICU admissions, and deaths in the 50 to 64-year-old adults, particularly those with comorbid conditions. We did something like this with pneumococcal vaccine when the age was lowered to 50 years of age for the chronic smokers. And I think because of the lower life expectancy in some racial ethnic groups, that it's really difficult to tell the true benefit of the RSV vaccine in that 50 to 64-year-old age group. And again, particularly those with comorbid conditions. And I think what Dr. Brooks was just alluding to, and I just remind everybody that race is a social construct. Obviously, we use race ethnicity to try and perhaps target certain populations or understand which persons are being suffering on inequitable, I guess, illnesses. But I think that's what you were struggling with, Dr. Lee, as well. But just I don't see this being a race-based recommendation. And I think that would not go over very well. And I think there would be more resistance. The risk base is difficult. So that's why I urge the work group to look at that 50 to 64-year-old group, and so that it may not have to be risk-based unless the risk is just having a comorbid condition in that age group. Thank you.
Thank you. And I just want to emphasize that I think while we use race, ethnicity, and earlier today was brought up, SOGI, to be able to identify where disparities may exist, it is a different thing to make a recommendation around it. And I don't feel comfortable doing that, just as you said, Dr. Whitley-Williams. So that's why I'm asking for what would give us the ability to make a clean recommendation. Dr. Long?
Yes, I think, and Dr. Cotton, who's the very capable chair of our work group, can chime in here if she doesn't think I have this right. But this was an unusual shared clinical decision-making decision, and it was because many of us were uncomfortable with the safety without the discussion of where are you over 60, what might be your underlying conditions, are you over 75? So that was more it rather than how much do you value preventing RSV. But we wanted to be sure that the people who got it, until we knew a little bit better about the potential severe adverse effects, that at least it was going in the arms of people who were at significant increased risk. So I am 79 on Halloween, and I got my RSV vaccine, and so did my husband, because that was shared clinical decision-making based on we would likely be severely affected. And the other thing is, we were very uncomfortable because in this age group in which I find myself, who were most likely to benefit, we had the least data of the performance of the vaccine immunologically, as not so much, there was not very many hospitalizations in any group, but because of those two things. So I would suspect, Dr. Cotton, you can see if you're sort of thinking the same thing, that within a year, and the data that we have seen, that 2 million people have received this vaccine, that we will have a little more clarity in at least the safety part. If there are continued to be safety signals, then we're really going to look very, very carefully at even younger people getting this, and depending on, you'd have to have not just an increased risk, but how increased is the risk to take this? Because if you look at the numbers, they're still pretty darn low, between 50 and 59 for hospitalization and severe outcomes. So those are a couple of things. Dr. Cotton, you want to add something?
Thank you. I think that's a very nice summary. When we made the recommendation for shared clinical decision-making, both for people 60 to 64 and then 65 and up, I had thought that we would reconsider that potentially once we had more available data. And so I think that's where we're at. We did not feel comfortable making a universal recommendation for 65 and up. That's not how we voted. Hopefully, like many other things that ACIP does, we evolve over time. We wanted people to have access to these 2 vaccines, RSV vaccines, this year. And so people with shared clinical decision-making, 60 years of age and over, who have it covered by their insurance, which turns out to not be all that many people who don't have Medicare Part D, which is highly problematic. So we did want people to have access, and I think that, like many things, this decision-making will evolve over time. And I appreciate the comments of the other ACIP members, because these are many of the things that we have discussed in work groups. So thank you very much.
Thank you. We do have to wrap up. I'm actually worried about our time, and we have many more sessions in. Dr. Sanchez, do you have a really quick comment?
Yep, I just wanted to comment as the person who I believe was responsible for the clinical decision-making with the last vote. I still would have done the same thing. I agree with the comments with Dr. Cotton and Dr. Long. I understand the implications and the time involved in clinical decision-making, but I also don't feel comfortable not spending that time before giving the RSV vaccine as it is currently, without that clinical decision-making, whether it was recommended or not. And so I'm still very much in favor of that we did it that way. I agree that with time, it may change, and I certainly agree that 75 years and over, I certainly would recommend it, and I do it currently. Thanks.
Thank you. With that, we are going to take a 5-minute break. So please return at 40 minutes after the hour. Thank you, everyone. And thank you to our presenters from the adult RSV group.